My name is Alok Khurana. I'm a medical oncologist and director of the GI Cancer Program at the Cleveland Clinic in Cleveland, Ohio. On this episode of Clot Chronicles, we will be discussing our new review of the prediction and prevention of cancer-associated thromboembolism. As many of you who take care of patients with cancer know that cancer patients are at high risk for venous thromboembolism, and that typically includes deep vein thrombosis and pulmonary embolism, as well as arterial thromboembolism, which is not as well understood, but includes a greater risk of stroke and myocardial infarction at the very least. The rates of these illnesses, venous events and arterial events, vary across cancer patients. They vary even in the same cancer patients over a period of time. And what we've learned from the last 10 or 20 years of sort of researching this area is that there is a high degree of risk variation within cancer patients, but that we can successfully predict the risk of at least of venous thromboembolism in this population using some risk assessment tools. In addition, we can focus on the high-risk population and consider primary prevention strategies. And there's been a great deal of discussion about optimal primary prevention strategies in this field. And I'm going to try today and cover both those aspects, risk assessment and primary prevention, in the specific setting of cancer-associated thromboembolism. Let's start with risk assessment first. There's certainly rudimentary forms of risk assessment. As I mentioned, I direct the GI Cancer Program. Anybody who takes care of patients with pancreatic cancer knows, for instance, that there's a clearly high risk of venous thromboembolism, much higher than most other solid tumors. Similarly, people who take care of patients with primary brain tumors also know that there's a very high risk of DVT or PE in that population. So that's one form of risk assessment where you recognize certain types of cancers are strongly associated with the risk of venous thromboembolism. A more sort of robust form of risk assessment involves a risk assessment tool that incorporates the type of cancer, but also 4 other variables. This is a tool that my research group and I initially published in Blood in 2008 using a national database of about 3,000 cancer patients. And this risk tool, now known as the Khurana score, has been validated in over 45,000 patients worldwide across multiple different settings and studies. And this risk tool depends on 5 simple variables. One, as I mentioned, is the type of cancer. So if you have pancreas cancer or stomach cancer, you get 2 points. If you have lung cancer or lymphoma, you get 1 point. Kidney cancer, you get 1 point. Most other types of solid tumors, so breast cancer, colorectal cancer, you get 0 points for those types of cancers. You can also get points for a high white cell count or leukocyte count of more than 11,000, a high platelet count of more than 350,000, a high BMI of more than 35 kilogram per meter square. So there's different ways to get to a high risk category, just the type of cancer or a combination of a high leukocyte count. A low hemoglobin is another variable in there, so hemoglobin of less than 10. So you could have a low hemoglobin, a high white cell count, and a high platelet count, and that gets you 3 points, which puts you at high risk. Over the years, the definition of high risk has evolved as well. In our original paper, we had proposed a risk score of 3 or higher as being high risk. But recent studies have shown that a score of 2 or higher is associated with a roughly 10% risk of VTE at approximately 6 months. And so that's been the definition more recently at which prophylaxis is being considered. So as I mentioned, there's variation in risk. Risk can be identified using rudimentary techniques such as the type of cancer, can be better quantified using a validated risk assessment tool. And the risk definition used to be 3 or higher, but is now evolving towards 2 or higher. Now, how do we use risk assessment to identify patients at high risk that would benefit from primary prevention? Again, the last 1 to 2 decades have seen a lot of research in this area. It's important to note that VTE in the cancer population can occur in both the inpatient setting and in the outpatient setting. We've known about the inpatient risk for a long period of time because we do inpatient prophylaxis for most cancer patients that are admitted to the hospital, and certainly for almost all cancer patients that undergo major abdominal or pelvic surgery. And this is based on data that goes back several years looking at inpatient prophylaxis and post-surgical prophylaxis. But the reality is that most cancer patients now receive the treatment in the outpatient setting. And so most clots, 70 to 80% of clots now occur in the outpatient setting, not in the inpatient setting. So we could be perfect with inpatient and post-surgical prophylaxis and still not prevent the majority of clots that occur in cancer patients. And recent trials, therefore, have focused on outpatient prophylaxis. The initial set of these trials were not risk adapted and focused on using low molecular weight heparins. They were successful in terms of meeting their primary endpoints, and these were trials using low molecular weight heparins such as navropirin. PROTECT was one trial. SAVE-ONCO was another trial using an ultra low molecular weight heparin called cimeloperin. And both these studies took a similar approach. They took a bunch of solid tumor patients. Half of them got outpatient prophylaxis with an injectable, daily injectable. The other half didn't. Rates were low. They were about 3.5%, 4%, down to about 1.5%, 2%. And so statistically significant, met the primary endpoint, but because the rates were so low, because patients were not risk adapted, those recommendations of outpatient prophylaxis were not widely made nor utilized. What's changed in the past couple of years has been this focus on risk adaptation that I just mentioned, as well as the advent of direct oral anticoagulants, or DOACs, which can be used orally and don't require a lot of monitoring. And so two large randomized trials focused on a high-risk population. These two trials were AVERT using apixaban and Cassini using rivaroxaban. And both these trials focused on a population of patients with a Corona score of 2 or higher, mostly solid tumor patients and lymphoma patients. AVERT also included some myeloma and brain tumor patients, and randomized to either apixaban or rivaroxaban versus placebo. And consistently, these trials found a reduction in the risk of VTE, slight increase in absolute risk of major bleeding. And so the number needed to treat, depending on the trial and depending on the meta-analyses, ranges between 15 to 25. The number needed to harm to have one major bleed is about 100 for both these trials. Based on the results of these trials, guidelines from ASCO, from NCCN, from ITAC, ISTH have all been updated. And all guidelines now recommend consideration of outpatient prophylaxis for cancer patients with a score of 2 or higher and that don't have a major bleeding risk. The most recent data and most recent research projects have now focused on how do we implement these trial recommendations and these guideline recommendations into clinical practice. Because as many of you who take care of cancer patients know, cancer patients have so many ongoing issues, so many different competing priorities. The cancer, obviously, the treatment decision, the side effects of treatment. And so who's going to take ownership of thromboprophylaxis? And there's different models for managing this, which we discuss in our review. One model is to introduce an electronic medical record alert. That's what we are doing at the Cleveland Clinic and at certain other institutions, where the score is automatically calculated and it's presented to the clinician, and the clinician's alerted before they go in to see the patient. And then the clinician can have a discussion with the patient about whether prophylaxis makes sense in that specific setting or not. A second model is the Vermont model that actually creates a multidisciplinary pharmacist and hematology physician-based service. And so high-risk patients are identified, and then they're referred to a hematologist, and then the hematologist has the discussion with them about whether they want to go on prophylaxis or not. This model was recently published in the JOP, and they found close to 95% compliance with prophylaxis for patients that were referred to the hematology service. So different models are currently being used to study essentially implementation science, how to implement the findings of clinical trials and guidelines. I talked mostly about venous thromboembolism, but briefly about arterial events. In at least one of the two DOAC trials, Cassini, arterial events were recorded and were rare, but were also reduced in numerical terms with thromboprophylaxis. And so there may be benefits beyond venous thromboembolism prevention into arterial thromboembolism prevention in this population with outpatient thromboprophylaxis as well. So to summarize, lots of exciting new data, validated risk assessment tool to identify high-risk patients, trials with both low molecular weight heparins and direct oral anticoagulants in terms of outpatient thromboprophylaxis. Definitely well-known data for inpatient prophylaxis and post-surgical prophylaxis. Those recommendations don't change. And new implementation science approaches to find the right model in terms of delivering and ensuring compliance with outpatient thromboprophylaxis. Thank you very much for taking the time to listen to me today. And references and citations for all of that I've discussed today can be found in a review that was just published in The Oncologist. Thank you again for listening.